And one of the terms that I think we're hearing a lot more of, not because it's a new term, but I think people are trying to figure out, well, how do we get at it, particularly through employers, is social determinants of health. We know that, so what is the saying, zip code predicts obesity rates better than diet. What are we doing? I know it's a challenge for employers to get their hands around this, but how does it manifest itself in our population health strategies?
A little bit of background I think is important to share, and that is that social determinants really have been the domain of public health representatives, and really not not employers or the commercially insured populations. And as a result, health plans really haven't looked at that. When we have evaluated claims data at the employer level, we've not looked at socioeconomic measures that may be associated with health until recently. And now there is a growing body of literature, and many more entities are looking at social determinants of health in commercially insured populations. One of the things that emerges very clearly is that wage is certainly a strong influencer of healthcare utilization. It's also, interestingly, a predictor of mental health illness prevalence, with lower income individuals having a higher prevalence of behavioral health conditions. Interestingly, low wage status is also associated with a higher risk of, or a higher prevalence of, unhealthy lifestyle behaviors. Those are in turn associated with a number of chronic conditions. So we've not historically looked at the association of social determinants in subpopulations of employees in commercially insured groups. And it's, I think, now incumbent upon us to start to look more seriously at those populations and embrace tactics and strategies, as the two of you have with your benefit design, to make access to care more equitable.
It'd be harder for us from a regional perspective, since we like to say we have a pastor in every zip code. I don't think it's quite that dense, but there are no real pockets. So in terms of community influence, I suspect, although we've not really looked at it, that those pastors in rural areas versus those in more urban areas, there are differences there. Access to care is different. But I don't think we've done anything specifically. We acknowledge we have very low paid. The pastors are low paid, but they're highly educated. So that's kind of a contrast right there.
Any thoughts on that, Andy?
No, I think it is seen. It's seen in the average lifespan. I mean, in New Jersey, I was looking on site just in the city of Newark. There's 4 wards. The ward's different in average lifespan by 18 years. One ward's is high. The other one is I think it's like 67 is the average lifespan. And then you go outside of Newark, and in areas it's up to 91. So just the discrepancy in longevity and mortality, again, which translates into more healthcare, chronic health conditions. So,
some of what we've seen is that as we talk about care navigators, but we talk about health navigators too, right? And getting more intimate with the individual. When those people get more intimate with those people, they're hearing issues that aren't just about what their diet is, but what are some of those underlying issues. And so indirectly, and on a more personalized basis, to your point before, they are actually understanding what some of those underlying issues are. And I think when we're starting to think about total health, we need to look at the total person's existence in that context, right? And actually helping them to navigate. It kind of ties into prevention, because we haven't talked a lot about prevention. Wellness is part of prevention, but what is the current state of thinking around prevention? Any thoughts?
I think in regards to primary prevention, it's very important. I mean, just the basics, the smoking, the activity, things like that are helpful. I think, as you mentioned, when you get into a disease and preventing the complications of that too, are things we've kind of just pushed to the side all the time, and I think we need to bring that to the forefront. But along the lines of education of the patient, or the healthcare consumer, we'll call them, and understanding the importance of prevention and what it means to them. But then also, what's their own thoughts, their bias, their cultural aspect in regards to this? That's got to be factored in there. I know that a lot of times, as you're doing a treatment with someone, based upon their background, their race, they may focus on the complications of the treatment versus somebody else who's focused on the advantages of taking the treatment too. And so, taking the time, having the time to understand for a provider, the person in front of you, what will be their mindset in following through and being compliant and walking through that. But that takes time, and that takes a relationship, not a transaction. And so many times we're dealing Medicare as a transaction.
Agreed. And I think we're talking around, I think, a central point here, and that is that individuals may have personal priorities that are very different from what we think they should be. And Mike, I think this gets back to the theme of patient-centeredness, where if we don't understand an individual's personal priorities, and we make a recommendation for a particular treatment or care, we may be completely missing the mark when it comes to what's important to that individual and whether that even is going to resonate for them. So if you have a low-wage earner who's maybe working 2 jobs, single mother who has high cholesterol, and we say to her, you really need to do a better job managing your cholesterol, that's not her priority. And we have been trained as physicians, and back in the day, at least for me, that wasn't part of the discussion. And it now needs to be, and I think that's what you're very much alluding to.
Yeah, people are motivated so differently. You can lead a horse. And if we had the trigger to what motivates certain people to do certain things at certain times in their lives, some need a heart attack. They need an episode to motivate a change. Others are willing and open. I think I'd love to have that answer.